Here's the honest positioning though. PRP doesn't erase arthritis on an x-ray. The goal is less pain, better function, and better tolerance to walking, exercise, the activities that you love to do, especially in mid to early stage arthritis. PRP actually is better in earlier stages than later stages of arthritic changes. If you're dealing with chronic heel pain, tendon pain, partial tendon tears, or arthritis in your foot and your ankle, and you're trying to avoid surgery or avoid living on steroid shots, or maybe steroid shots have stopped working for you, this video is for you. I'm Dr. James Repko at Bayshore Podiatry Center, and at our clinic, we use PRP for very specific foot and ankle problems where we see strong real-world results, especially when it's paired with the right rehab plan, and in many cases, we do additional shockwave or MLS laser therapy as well. I'm going to be very direct with you. PRP is not one product. PRP outcomes can look inconsistent because different PRP systems produce very different mixtures of platelets, white blood cells, and even have some red blood cell contamination. So today, I'll explain what PRP is, platelet-rich plasma, why concentration in leukocyte-rich versus leukocyte-poor matters when you're selecting your PRP system, what conditions we treat with it, and what results I think are realistic for people to expect when they're pursuing something like platelet-rich plasma or PRP injections. Quick disclaimer, this video is educational and not personal medical advice. The only way to know if PRP is really right for you is an exam and usually imaging. Definitely want to seek a professional opinion. Here's the biggest misconception about PRP. People think it's like a medication like you would get at the pharmacy. Same product every time. The problem is it just isn't that simple. Studies comparing PRP preparation systems show really substantial differences in what comes out. Platelet concentration, leukocyte concentration, cytokine and growth factor profiles vary depending a lot on the method and the device. So when someone says, I've tried PRP, but it didn't really work, my first question to them is, what did you actually receive? Because PRP isn't just a label, it's a formulation. So what system did you use? How many injections did you have actually? And what amount of blood was drawn to prepare that injection? What is PRP actually? PRP is platelet-rich plasma. It's when you draw up your own blood, concentrate the platelets into a smaller volume, and then inject it precisely into a tissue or joint that we're specifically targeting. Platelets carry signaling proteins that can influence inflammation and tissue repair responses. But what really matters clinically is the quality and the consistency of the PRP and how accurately it's placed, making sure that it's in the right area. My view is simple. Dose matters and consistency matters. In osteoarthritis research, there's evidence that a higher platelet dose may be associated with better outcomes. That doesn't mean that it's necessarily directly translatable to foot and ankle, but it is the closest research of high-quality studies that I can find that translate across the board. It does make sense to take and extrapolate things that are working in knees to smaller joints as well, but it's not apples-to-apples comparison. That said, the dose is not irrelevant here, and it's why we care about reproducibility whenever we're selecting PRP for our patients. If the PRP product is all over the place, you can't expect consistent clinical results. And there's two different types of platelet-rich plasma as well, leukocyte-rich versus leukocyte-poor. So leukocyte-poor or LP PRP generally reduces the white blood cells. Leukocyte-rich or LR PRP contains more white blood cells. For osteoarthritis, many clinicians lean towards leukocyte-poor PRP because higher leukocyte content drives more inflammatory signaling and typically is more painful. There's still debate on that in the literature, but it's a pretty common approach from a literature perspective to use leukocyte-poor PRP whenever you are injecting into a joint. For tendons and fascia, it's not one size fits all either. Tissue type, chronicity, and symptom pattern matter. The key point for you as the patient is we tailor the PRP to you and your specific needs. So typically with tendons and fascia, we're using leukocyte-rich to get that inflammatory response that we want in the tendon. It is a little bit more sore though. At Bayshore Podiatry Center, we use the Arthrex Angel system because I believe that it gives us the best control. Independent studies show that PRP systems can produce meaningfully different compositions, so those factors that we talked about earlier in the video. We want a system that lets us dial in specifically what we're trying to deliver, especially controlling things like red cell and leukocyte content, so we're not guessing at all whenever we elect to pursue PRP. Does a device name magically make PRP work? No. But reducing variability and improving consistency is a legitimate clinical concern and goal when you're trying to deliver reliable outcomes. Consistency matters ultimately with these things. So what are some things that we use PRP for in our clinic from a foot and ankle perspective? For chronic plantar fasciitis, especially when someone has failed the basics, PRP is one of my favorite tools because the evidence is fairly supportive compared to steroid injections with longer follow-up, especially when you look outwards of a year. Steroids kind of fall off a cliff and PRP really maintains progress in plantar fasciitis. People tend to be able to maintain activities longer and have less pain with PRP compared to steroid injections. Thing with PRP, where it differs from a steroid injection, is it doesn't give you that instant relief that a steroid injection does. Steroids feel great fast, and I'll often use them if somebody is in debilitating pain. I say 7 out of 10 pain or greater, a steroid's a great tool, as long as it's in the right place. But steroids can also be short-lived and come with trade-offs. PRP is much more of a build over time approach. It's stimulating your body's natural healing mechanisms. We'll also use PRP for tendon pain, including partial tears, including partial fascial tears, to avoid surgery. We especially use it in degenerative changes in these partial tears when the situation is appropriate and the patient is trying to avoid surgery. It seems to work really well in my hands. This is where our protocol matters too. It's not PRP alone. We structured it with a paired progression and in many cases focused on radio or shockwave therapy where it's appropriate as part of the overall plan. We also always incorporate that with some type of physical rehabilitation because that is extremely important when you're dealing with tendons and fascia. There's clinical research in other tendinopathies suggesting PRP plus shockwave can improve early pain relief compared with PRP alone, which is why we do it. We kind of think of it as supercharging the PRP, if you will. Foot and ankle specific combination of evidence is still developing, so we don't present this as a magic pill, but we present it as a logical stage protocol. To me, it just makes sense from what we're trying to achieve standpoint. We're trying to maximize the benefit from the injection itself. We also use it for osteoarthritis of the foot and ankle. Select cases of osteoarthritis in the foot and ankle joints, including the big toe joint, the first metatarsophalangeal joint, what a lot of people call hallux rigidus. We use it a lot there. Here's the honest positioning though. PRP doesn't erase arthritis on an x-ray. The goal is less pain, better function, and better tolerance to walking, exercise, the activities that you love to do, especially in mid to early stage arthritis. PRP actually is better in earlier stages than later stages of arthritic changes. When you zoom out, there are systemic reviews looking at PRP for hand and foot osteoarthritis showing improvements in pain and function compared with controls. Although study quality and protocols do vary quite a bit, which makes this kind of difficult to wrap your arms around and why I'm here talking about it today. Specifically for hallux rigidus or great toe joint arthritis, injections as a category are commonly used in early stages for symptomatic relief. And the best studied injectables historically are steroids and hyaluronic acid. Our approach is very selective. We confirm the painful spot, the pain generator, often trialing with the steroid first. We want to optimize your mechanics to offload the joint and strengthen the tissues around the joint, and then decide if PRP makes sense for you at your stage and depending what your goals are. Now, specifically related to ankle arthritis, I'm going to be direct. PRP is not a guaranteed win. The best ankle osteoarthritis trials versus a placebo in a controlled randomized trial, which was published in the Journal of American Medicine, found that PRP did not significantly improve symptoms and function compared with a placebo or like a saline injection, saltwater injection, or maybe a glucose injection at 26 weeks. PRP did have better short-term outcomes, but the long-term really wasn't there. So what do you actually do with that? Well, in our clinic, we don't oversell it. I think candidate selection is critical to outcomes, and we set the goal as pain and functional rehabilitation and improvement, not fixing what is actually going on. It's not going to magically regenerate cartilage. And we track the outcomes. Some patients do very well with PRP, some don't. Especially when inflammation load and management are the main drivers, PRP excels. If we can manage the load and control the joint better, PRP can do a great job for you with arthritic conditions about the foot and ankle. Here's what a realistic PRP injection timeline looks like. At days 1 to 7, there's some soreness and you have an inflammatory response. This is where I think laser and shockwave help reduce some of that. Weeks 2 to 6, symptoms start to improve and settle and function begins to improve. Weeks 6 to 12, this is where many patients notice the real changes. Walking tolerance, exercise tolerance, morning pain are usually the first things to improve with successful PRP injections. If you're expecting to come in, get PRP, walk out, and be better, PRP isn't for you. It's not the solution. It's a long-term build over time. What's the safety of PRP? Well, since PRP is using your own blood, allergic reactions are really uncommon. Risks do still exist. You can have infection from the injection site, bleeding, nerve irritation. We avoid this by using ultrasound guidance, and there's the possibility of post-injection pain flares because of the inflammatory response that this does stimulate. So how do you make a decision on whether or not PRP is right for you? Here's my quick decision framework. Do we have the right diagnosis and the right target? Are you a good candidate for PRP based on imaging, exam, your goals, what you've done so far? What PRP formulation is going to make sense for you if you are a candidate? Do we do leukocyte-rich or leukocyte-poor? Is it tendon versus joint? That plays a role. What's the rehab plan? Because I think this is a big part of it. You have to have a focused rehab plan as well. And what's plan B if you don't respond to PRP? So if you are in South Tampa or the Tampa area in general, and you want a clear answer on PRP, whether or not you're a candidate, not guessing, book an evaluation with us. There's a link in the description below. We can review imaging, examine you, and lay out a plan that's conservative first, but not passive, and tell you if you're a good candidate for PRP. Some people are, and some people aren't. Hope you found this useful in deciding whether or not PRP is right for you, and hope to see you in our office.